Okay, good morning. We've got a little melding of the worlds today with some neurology presence. But before I begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to enrich our vibrant community. So delighted to introduce Dr. Richard Camicioli from the Division of Neurology in the Department of Medicine. Of course, most of us know Richard as a professor of medicine at the university, where he directs the Cognitive Neurology program and is scientific director of Movement Disorders program. He's a member of the executive committee of the Canadian Consortium on Neurodegeneration of Aging. His research interests include the identification of predictors of cognitive decline in aging and Parkinson's disease. Current research focuses on two funded ongoing interventional trials, including exercise in early Parkinson's and lifestyle interventions for mild cognitive impairment, as well as the comprehensive assessment of neurodegeneration and dementia study examining the natural history of neurodegenerative disorders. So really interesting title, Richard, Neurodegeneration in Aging, Exorcising or Exorcising. So with that, I'll hand it over to you.
To look at, get my thesaurus out to think about titles. So thanks so much. I'm honored and a bit daunted by being here at Medicine Rounds. I'm proud to be part of the Department of Medicine, actually. Some people want to separate, but I'm fine with that, and actually very pleased to be part of that. So what I'm going to, again, I thank you for doing the land acknowledgement. I think that I was thinking today we have a land and water acknowledgement, which we should really roll out, which we're privileged to be a part of. And we're actually, although we're in Treaty 6 territory, Treaty 7 is just south of us. All of our work in Alberta is up Treaty 6, 8, 7, and 8. So I think it's really important to respect where we come from. So the goals today are to kind of review the prevalence and incidence of age-related neurodegenerative disease. I mean, and try to make the point that this is highly relevant for all of us in society and in Department of Medicine and certainly in neurology and geriatrics and areas where it's kind of more obvious that it's relevant, but it's relevant to all of us. We'll talk about the differential diagnosis, highlight features of Lewy body disease. These are important disorders that are important to recognize. They show up as patients in the merge. They show up patients on our ward, and we're wondering why they're not getting better. So I think an important group to be able to identify and recognize, and talk quite a bit about non-pharmacological interventions for the treatment and prevention of cognitive decline. There's a lot on pharmacological interventions happening in the world, and you can definitely ask me questions about that, but I'll really focus on the non-cognitive and the reasons I think I'll try to make clear. So I don't know if anyone's seen the play Hadestown. So Eurydice and Orpheus make some choices in life, and some of those choices lead to bad things. And so we all have choices to make, but the problem is the fates sometimes kind of overwhelm those choices. So I think that's the message in that play. And as I was thinking of this, I was thinking, yeah, we've got to make choices. We've got to make good choices, but sometimes we just can't. So the hope is that we make the choices that keep us with normal cognition, although people will progress to have mild cognitive impairment, defined as cognitive impairment short of functional impairment, in other words, not dementia. And dementia is sort of a stage which we don't want to reach. And there may be ways of preventing these transitions from happening so that we don't have to go see the exorcist and deal with the novel therapies that are coming out in Alzheimer's disease. So mild cognitive impairment is really quite common. If you look at a group of people over the age of 80, about a quarter of people will have that, and half again will have dementia. So you're talking half of your admissions of an 80-year-old might have dementia or mild cognitive impairment. So these have implications. And so I think that's the idea, is we should be able to recognize these syndromes. They're syndromes, and they're made up of different pathologies and different contributors to the cognitive impairment that you see. So the prevalence of neurodegenerative diseases affecting cognition is increasing worldwide. aging is the predominant risk factor affecting the prevalence, in other words, the proportion of the population that has the disorder at a specific time. And there's a lot of geographic and disease-related variation in that. And it was decreasing in the West. There's a number of studies from Western Europe that showed a decreasing incidence of dementia in Western world. A number of these studies are from Dr. Q in Stockholm. And the problem is that this trend may be reversing. We're not sure why it went down. It's thought to be better general health, better education, better lifestyle. And we'll get specific. We'll drill down into some of those things. But it may be increasing again. It's turning around. And in the Eastern world, in China, Japan, Korea, the prevalence prevalence and incidence are increasing. So there's lifestyle factors that have an impact. Parkinson's disease is a super growth industry. It's actually growing, actually, as is ALS. Wendy's here in the audience. So ALS is also, these are the incidence and prevalence of these disorders are going up. So this is, again, going to be a bit of a future epidemic of neurodegenerative diseases, and a lot of them can come in the context of other disorders. So how do we prevent them? I'm just going to start with how do you prevent them? So this is a really influential study that everyone should have a look at. This snake diagram, Wendy thought this was a snake diagram, identified population attributable risks of certain risk factors. And the argument that Gil Livingston made was that if we address these issues, you might prevent half of cases of dementia, 40 to 50% of dementia. This was the original list. In 2020, they've had a number of iterations. So high HDL was added because there was more evidence. It wasn't that high HDL was a problem, or was not considered a problem. We treat that, we think about that, but it was identified as a risk factor for cognitive decline. Visual loss, also there was some evidence. And the evidence reached the level that that they could analyze it and believe that this was a risk factor. A number of things are preventable. Education, hearing loss is something that really is important. That's actually influenced my clinic. So people with mild cognitive impairment with hearing loss, this actually can prevent cognitive decline. Again, I remember giving a talk in McGill, and there's a researcher looking at hearing loss and how it affects the brain plasticity. Get your hearing checked. If you can't hear the talk, get your hearing checked. If I can't hear your question, I should get my hearing checked. A number of other things like depression's been well known. Brain injury, we got to prevent it. Physical inactivity, we'll come back to that because this is, again, what the last part of where we can have an intervention comes in. Vascular risk factors. Again, this is something that everyone in medicine is going to be dealing with every day, but we can't forget those in primary care. Sometimes people, for example, with a Parkinson's disease, have a lot going on. Their motor function isn't good. And one forgets that they've got a background, which includes a vasculature that could actually be intervened upon. Excessive alcohol, social isolation, air pollution. Air pollution is one of the reasons that people are thinking that potentially the risks of dementia and cognitive impairment are going up. So keep this in mind. Let's prevent it. But if we can't prevent it, why bother identify it? Oh, the last one is this list is going to probably evolve. And this is just hot off the press from Cell. It's a wonderful study from Wales where if your birthday was on one side of I think July and then the other side of July, I can't remember if it was exactly July, but there's a birthday cutoff. Prior to that date, you got the shingles vaccine. After that date, you didn't get the shingles vaccine. So it was a natural study, pretty well randomized. A +1 in birthday is not going to affect your dementia risk. And what it's been shown is that shingles vaccination alters not only the incidence of dementia, but also alters the course. This was what this new Cell paper added, was it actually alters the course. People do better if they get mild cognitive impairment or dementia if they've had their shingles vaccine. And when I was sort of preparing today, this will probably enter the list of Gil Livingston's list in the next iteration. The data is really accumulating, and so one of my interventions to my infection colleagues was get your shingles vaccines. They hadn't yet. Our neuro infection colleagues, so they've got their vaccine, I hope. Actually, it's true of other vaccinations, so pneumococcal and influenza. So these all may prevent and potentially help the course of somebody with dementia. So why bother identifying? So we just talked about preventing it. We can prevent half the cases, nothing to do, right? Well, I think you'll get the message. It affects someone's prognosis. If you know you have mild cognitive impairment, you know, your future longevity, your future course in life may be affected, and then you can potentially alter how you manage things. So one can learn what's going on. People's thinking is changed. I always tell people in clinic that, you know, this is what's happening. Now let's talk about what we can do about it. But knowing what's happening is respectful of the patient. And then one can think about supports that may not be necessary initially, but happen as the course of the disease progresses. Think about comorbid diseases. Remember, we talked about those risk factors for cognitive decline, but you need to manage them as if people have cognitive decline already. A fixed medication selection. So anticholinergics is one of my favorite consults. Doesn't happen that often now that we have Connect Care. You identify somebody who's having, actually I saw a patient in clinic like this a few months ago. Why are they demented all of a sudden? Well, they had cognitive impairment, probably mild cognitive impairment, but they were on a whopping dose of anticholinergic drugs. And that was like the cure. I mean, it wasn't the cure. They still had mild cognitive impairment, but you know, you can identify medications and select medications differently. Health and wellness, again, going to be the theme later on in the talk that I'm going to really emphasize, but health and wellness can affect, you know, the incidence, and also can affect how you do with a cognitive disorder. And obviously, one of the things that kind of is a common question is people actually notice that their spouse, their loved one, their partner, their parent is having behavioral changes, apathy, changes in maybe agitation. These can actually be a signal for cognitive decline. And they might not notice the cognitive decline because the behavioral decline is what's really sort of bothering everybody. So understanding why that is happening and what that might portend is important. Safety is another issue. Don't talk about weapons too much in Alberta, but I used to do it all the time in Oregon because I worked at the VA, and the VA, everyone drove up with their truck with guns sitting in them. I probably should be asking about those given our policies here. And then obviously planning personal directives with healthcare planning. And then finally, treatment. And at the stage of mild cognitive impairment, all these issues are things that need to be considered, but you can actually increase social and cognitive engagement. You can actually improve nutrition, and you can introduce exercise. And these actually are the only things at the stage of mild cognitive that delay developing dementia. And dementia is where you need help. So certainly you want to address the potential need for help, but if we identify things early, you can actually affect people's outcomes. So this is on the top slide is a slide of people with Parkinson's disease. And if you have cognitive impairment, mild cognitive impairment, without functional affecting your functional independence, your risk for functional dependence, in other words, dementia, increases over time. So how do you identify? So there are some prodromal features. I mentioned mild behavior changes may be a prodrome to mild cognitive impairment. Obviously, if you have cognitive impairment, that's objective, then you've got mild cognitive impairment, so you've identified it. People start noticing cognitive impairment before we can actually identify it on tests. And so that's really important if you're working in outpatient clinics or you're admitting a patient and saying, yeah, they've been having some cognitive concerns, but they've been fine. They've been independent. They were tested in geriatrics. They have a MoCA of 45 out of 55, whatever they have, 30 out of 30. So subjective complaints actually are a concern. Less known about what to do there, but I think that's a good opportunity to intervene and to consider lifestyle changes. Mild motor impairment, so slowing, people who slow down with age, is that normal? Well, it's common, but it's not normal. And some people actually come in with the presentation of they're slowing down, they're not walking as fast, their thinking is slow. So that's termed mild motor impairment. On the right, and gait changes are common as a manifestation. So on the right, this is a study by a colleague, Joe Verghese, where he looked at people who had subjective cognitive impairment and mild gait changes. So they had slowing, a 1 standard deviation below a normative group of patients. And they found that those who had both of these things were double the risk of developing mild cognitive impairment and double the risk of getting dementia. So half were okay, and then more than half were not okay. 3/4 were not okay, who had subjective impairment with objectively normal test scores. So I think that's important to consider when you're seeing patients. And then especially this is especially true in the outpatient clinic, but some people come into the hospital with that history of these kinds of changes. Again, we talked a little bit about behavior, apathy, anxiety, depression can be prodromes to dementia. Hallucinations, actually, some people have visual phenomena and they're not sure what they are, and they can have nothing else. So that's important to recognize. Sleep changes. Obstructive sleep apnea is probably, apart from after hearing loss, probably the next most common thing we see as an intervenable thing in clinic. Autonomic changes, urinary, gastrointestinal symptoms. Again, when I gave a talk, like my first talk here, or one of my talks, like it was my first talk, the gastroenterologist thought, can I send you all my constipated patients because they might have dementia? Well, no, thanks. But and again, you have to deal with the structural and behavioral issues that are related to that. But all these can be prodromes to dementia. So autonomic changes and sensory changes. We've talked a little bit about hearing loss, but also vision and smell. Some of these features, such as fluctuating cognition, Parkinsonism, the neurobehavioral things, REM sleep behavior disorder, where you act out your dreams, you kick and scream in the night, specific urinary changes, orthostatic blood pressure changes. Again, I think orthostatic blood pressure changes may make the next iteration of the Lancet Commission, and sensory changes, especially smell loss. These are prodromes to Lewy body disease. So you've got the global approach to identifying somebody at risk for mild cognitive impairment. You should be able to identify mild cognitive impairment based on history and testing and lack of functional decline. But these other features may suggest a specific etiology for your cognitive decline. On the right is another slide of a colleague, Manuel Montero Das. It's a study we participated in. And I actually have to thank Dr. Ballerman for getting us a gate lab so we could participate in this study. But so thank you very much. And so this shows that actually people who slow down while walking, when doing, and this first panel is a serial subtraction task by subtracting 1 from a random number, so 50 minus 1, 49, 48, 47, while you're walking, had triple the risk of developing dementia if they had mild cognitive impairment. So again, we can stratify our risks a little bit by refining how we assess things. So Manuel just got a grant, and we're on the grant. I don't think we're going to get too much money here, but we're on the grant where the idea is we're going to try to see if we can implement some of these, take these mild cognitive and mild motor and mild non-cognitive aspects and see if we can implement it in primary care. So the idea is we're going to actually look at models to see if these help our prediction of dementia, and to see if these can be implemented in primary care, working with people in Ottawa who are implementation scientists. So one of the sleep disorders that we can recognize from that history is REM sleep behavior disorder. So this is a slide by Steve Josa, our new colleague in the Department of Medicine and a Neurology division, who looked at basically put together a big population of people who act out their dreams. Not all with polysomnography, but the majority had polysomnography to be sure that this was REM sleep behavior, not something else like seizures during the night or obstructive sleep apnea. And what he found was over time, if you take someone with this prodromal feature and see how they do over time, a group of them progressed to either Parkinson's disease or dementia with Lewy bodies. Of note, the people who progressed to dementia already had cognitive impairment. So they were people with mild cognitive impairment with REM sleep behavior disorder. So they would actually meet criteria for something called Lewy body mild cognitive impairment. So identifying that was important because they progressed more rapidly than actually the control group without cognitive decline. So again, this is a different group, but again shows that we can maybe identify people at risk, again potentially intervene with them. So Lewy body dementia is a specific dementia where you have progressive cognitive decline. That's how you define dementia, with functional impairment. And then the cognition is fluctuating. Remember, that was one of the potential prodromal features. People might have visual hallucinations. People can have REM sleep behavior disorder, as I just said. And people can have Parkinsonism, but not enough to necessarily diagnose them as Parkinson's disease. So maybe a little bit of tremor, a little bit of rigidity, or rigidity but no tremor, so they're very can be a little bit subtle, so it does take some experience to identify them. But these are the criteria for Lewy body dementia. And McKeith, who came up with the original criteria, also said, well, they must be a prodromal stage, and that's where mild cognitive impairment with Lewy body features. And in Steve's study, maybe even before that, and that's where the prodromal features that are not cognitive are important to recognize. This is a study from the Mayo Clinic, kind of getting at the idea of how, what proportion of our patients with mild cognitive impairment might be in this ballpark. So what they found was this is basically it's not really a truly population-based study, but it's more of a convenience sample, but a large number of older people who are followed over time in Rochester, Minnesota. And what they found is if you had memory loss, and this is the blue here, you almost always progressed to Alzheimer's disease. A few didn't, a few had other features. If you had other cognitive domains affected, so like planning, attention, visuospatial function, orientation, those things as an early feature, you progress to Lewy body dementia over time. So again, and again, those who progress to Lewy body dementia, this is the lower line, progressed faster than those who had Alzheimer's features. So the cognitive profile can help us a little bit. It's really hard to get neuropsychological testing. Sandra's in the audience. Could you do some testing for us? But that profile is useful. I mean, the Montreal Cognitive Assessment Test does kind of allow you to kind of roughly decide on the cognitive profile, because there are people who have just memory problems with nothing else, and people have other things without memory problems. So it is a crude way of doing it. This is another study looked at predictors of dementia with Lewy bodies, and they found that cognitive fluctuations from MCI, from mild cognitive impairment, REM sleep behavior disorder, mild Parkinsonism, not surprisingly, and impaired visuospatial and fluency with spared memory, which fit with the Mayo Clinic. And again, this other study, which is from a clinic, it's a clinic-based study, so it kind of really fits a little bit more like what we'd see in geriatrics or neurology if you're seeing cognitive patients, or internal medicine, or family practice. It was also about 20%. So about a fifth of the people who you see with mild cognitive impairment will have Lewy body disease, who eventually evolve into Lewy body disease. There's some markers. We actually have some of these tools available. So these are clinical diagnoses, and clinical diagnoses are pretty good, but there are some markers. So we talked about the cognitive profile, the two boxes at the top. Polysomnography, doing a sleep study, again, which we don't have as much access to as we'd like, but very important. If you have answered the question of do you act out your dreams, do you kick or scream in the sleep, probably REM sleep behavior disorder, but ideally you'd want to do a polysomnography. Cardiac denervation and MIBG scans, which can affect exercise performance in people with Parkinson's disease and Lewy body disease. Dopamine denervation on PET scans or fluoropropyl CIT scans. We actually do these. We can do these. We rarely need to do them. Quantitative EEG is not used clinically here, but can be used. It actually can identify attentional fluctuations. And then FDG PET scans are something we do once in a while. So this white dot in the middle is the cingulate, and this is the cingulate island sign. That area is spared in Lewy body disease and is hypometabolic, is dark in people with Alzheimer's disease. So this can be a useful test. But again, most of the time you can identify these people clinically. You don't need to go to these tests, but sometimes it's hard, and sometimes that's worth doing. This is amyloid PET scans. Amyloid PET scans are being introduced, and they can identify Alzheimer pathology. So we're getting to the Alzheimer end of the spectrum. The caveat is some people with Lewy body dementia have Alzheimer's pathology as well. So then you find Alzheimer's pathology, but if they're fluctuating, they're hallucinating, and they're Parkinsonian, they probably have dementia of Lewy bodies. You don't have to change the diagnosis. And then we do get MRIs frequently, and you can actually look at the pattern of hippocampal atrophy. Now, we do have available spinal fluid tests. So in Alzheimer's disease, you have lower A beta 42, higher A beta 40, higher tau. So you can actually do these tests a little bit, have to do an LP. Usually I'm doing them, or we're doing them in patients who you're really, the diagnosis is really critical. This is going to become more important as new amyloid chain altering therapies are becoming available. So we can do these. This is becoming available. Tau PET is not really available locally, but tau correlates best with cognitive decline. So it's actually a useful thing to think about down the road. So again, we have some biomarkers, but again, these are clinical diagnoses complemented and supplemented and supported by the biomarkers. What about Parkinson's disease? Now, we talked about Lewy bodies. So Lewy bodies are also the pathological correlate of Parkinson's disease. So people with Parkinson's that are at high risk of dementia. I'm not going to do a multiple choice test because the audience is here. I'm just thankful you're here. But about 80% of people with Parkinson's disease develop dementia. So that's higher than that proportion we said in the general population. What are risk factors in somebody with Parkinson's? And the pathology is Lewy body pathology. Actually, usually in the absence of Alzheimer pathology, but we'll get to that. So people with Parkinson's are, the definition: tremor, rigidity, bradykinesia, rest tremor in general. Have to do a good exam. Rigidity is a hard one to teach. I've actually done some reliability studies with that. It's a hard one to teach. But if you have Parkinson's and are older than age 70, so age 70 is an important cutoff. Over age 70, for example, deep brain stimulation is a treatment for fluctuations in dyskinesia in Parkinson's. If you're over 70, we're very, very cautious. I'd say we're unlikely to offer deep brain stimulation because you actually have a risk of declining after the surgery from a cognitive perspective. So so for some reason, this came from data, but 70 seems to be an age that's not so good for Parkinson's patients. Some aspects of motor features are predictors of cognitive decline. Big ones are orthostatic hypotension, REM sleep behavior disorder, and hallucinations, not necessarily surprisingly. And all these happen on a background of education, physical activity levels. Try to avoid head injury, try to avoid toxins like environmental pollutions, and try to have a good diet. We'll come back to these. And then there's a genetic background for cognitive decline in Parkinson's. So Parkinson's disease patients, this is another Lewy body patient. The terminology has now changed. If you have dementia with Parkinson's or dementia with Lewy body, these are Lewy body dementia. So the umbrella is Lewy body dementia. The difference is the timing of the onset of the cognitive impairment. Within Parkinson's disease, you should have Parkinson's disease for at least a year before cognitive decline. If you have them within a year, you call it dementia with Lewy bodies. They all have Lewy body pathology. Dementia with Lewy body patients have more Alzheimer pathology. So this is an example of the kind of pattern you might see in somebody with Parkinson's. This is from a study where we did years ago, and what we followed was people over time. And people with Parkinson's this is scoring of the clock drawing. You can score the circle, you can score the hands, etc. And so people with Parkinson's had lower scores on spontaneous clock drawing than people without Parkinson's disease. If you did a copy of a clock, you drew them a clock and they copied it, they did fine until down the road, and by the end, not everyone had problems, but those who had problems, some of them had. This is the spontaneous drawing, but the copy was just as bad. So this is again a brief test that you can do in clinic is clock drawing, and it's not a perfect test, not super sensitive. But for example, in clinic, when patients are leaving, they say, "Oh, by the way, they're having cognitive decline. I might do a clock and then kind of plan some further testing." So I mentioned that in people with Parkinson's, it's rare. They don't have as much Alzheimer pathology. Lewy body patients have more Alzheimer pathology. So this is a PET scan. Walter Metzler is a very active researcher in Europe, showing Alzheimer brain on a PET scan. Bright, bright, bright. That's your amyloid depositing is an amyloid PET. This is Parkinson's dementia and control. So not much difference between the two. But this may be a little bit misleading. So when the lab looks at a PET scan, they set a threshold, and the threshold can be above normal, but not in the range that is diagnostic of Alzheimer's disease. So CSF gives a little bit of a better window into this. And so spinal fluid, amyloid can be measured in the spinal fluid. And this is a study that followed people with Parkinson's longitudinally and found that those with low CSF amyloid, and low CSF amyloid in the CSF or the blood, and we'll get to blood in a second, is associated with Alzheimer pathology, but not the damage, not the tau damage that you might see down the road from Alzheimer's disease. And only those with low CSF amyloid, in other words, coexistent amyloid pathology, progressed. So it's a bit of a simplification that they're completely independent. There's more pathologies of one kind than the other, but they're not completely independent. And this makes sense from the dementia perspective. This is from a large brain bank in the US, the NACS brain bank, where they looked at people with Alzheimer's, and they found that in those who had Alzheimer neuropathology, over half had a coexistent pathology. A third had Lewy bodies, a third had vascular. And then some people were unlucky enough to have both. And again, has implications for prognosis. Because if you had Alzheimer's plus Lewy body, you're the most, this is a functional scale, up is worse. You had the most rapid decline. Alzheimer's is pretty bad on its own. And with mixed Alzheimer's and vascular, that also was pretty bad. But if you had pure pathologies, you'd actually tended to do better. So again, these pathologies they tell us that if we can identify somebody with those pathologies clinically, we can say, okay, this person is going to do worse or better. So we decided to look at this Lewy body group in our national cohort. As mentioned, that's one of the studies I'm on the executive and working on. This Compass ND is a national cohort that collects a breadth of data from across the country. In Alberta, Eric Smith leads the program in Calgary, and I'm here. We've actually collaborated really well with Eric Smith, but all the sites collaborate together. And what it's basically recruited is a breadth of people with different neurodegenerative diseases, not focusing only on Parkinson's or focusing only on pure Alzheimer's disease. And so we were kind of in charge of making sure that nationally we recruited people with Parkinson's disease and without cognitive impairment, including dementia and dementia with Lewy bodies. And then a group of people with mild cognitive impairment, 272 were recruited nationally. So a broad spectrum without like barriers. So somebody with Parkinsonism who might have cognitive impairment, could be Lewy body disease, was recruited. So we kind of didn't have the kind of the harsh separation between groups. The other thing is we're talking to Daryl before the talk. We have a wealth of deep data, including imaging. I'm not going to show much of the imaging, though I do have an interest in that. Sensory measures, the diagnoses are verified clinically, but also at autopsy for those who agreed to that. Lots of neuropsychological measures and serum and plasma biomarkers, including genetics, microbiome samples. So study partner questionnaires, they actually have a conversation so you can listen to their speech. So a lot of depth of data. So we wondered, given our interest in Lewy body disease, what proportion of people with mild cognitive impairment had features of Lewy body disease, and we thought we could compare them to people with Parkinson's with mild cognitive impairment and Parkinson's disease to see if there's differences. We identified it from the physical exam portion of the study. Could identify whether they had rest tremor, bradykinesia, rigidity, or increased tone. They weren't diagnosed with Parkinson's disease, but these features were identified, were checked off in their exam. We have a questionnaire that identifies all kinds of behavioral symptoms, but asked about hallucinations or delusions. The delusion question is they have false beliefs. So I thought that could be misinterpreted by an informant as a hallucination. So hallucinations are the diagnostic feature, but delusions also occur. And then the REM sleep behavior disorder question. Have you been told or suspect yourself that you have acted out your dreams while asleep, for example, punching, flailing your arms in the air, making running movements, etc.? And this was a yes/no question. It's about 80% sensitive and specific for REM sleep behavior disorder. And then cognitive fluctuations were asked by asking if people lost their train of thought in conversations, had staring spells, daytime sleepiness, taking naps. So we called somebody having cognitive fluctuations of having more than one of these symptoms. So by applying those features to the MCI group, we found about 40% have met criteria for possible, which is one of those features, or probable, which is two of those features. About 20% of people with MCI in the Compass ND cohort had this pattern. So we looked at their cognitive function. So we looked at various areas of cognition and found that the Lewy body MCI group was very similar to the regular MCI group. But the Parkinson's MCI group, we didn't know this at the time, had more impairment in memory, executive function, processing speed, language. All these were worse than healthy controls. And the Parkinson's MCI had more visual spatial impairment, more recognition memory problems. And then actually the other area that they were affected more is in social cognition, which Alexander Loverock, who's a med student, analyzed over the summer. We also looked at their biomarkers. So plasma biomarkers are currently, they're out there. The FDA actually has approved plasma biomarkers for identifying Alzheimer's co-pathology. So that's actually, we're talking with the lab to see if we can get plasma biomarkers available here. Save a CSF for people who are not worried about something more serious in. Well, this is serious, but something like an infection or an inflammatory disorder, something like that. So looking at the pattern, the Lewy body MCI had a pattern more suggestive of Alzheimer's with elevated tau and elevated GFAP, which also suggestive of Alzheimer's. So looking here, we see they had an Alzheimer pattern that was more Alzheimer-like than even the non-Lewy body MCI, and the Parkinson's MCI did not have that pattern. Tau was markedly elevated. Tau was also elevated slightly in the other MCI groups, and then GFAP was quite elevated, again, also elevated in the other MCI group. Neurofilament light, which is a non-specific degeneration marker, which you can actually order because it's used in prognostication in following MS patients, is actually elevated across the groups, was not useful in differentiating the groups. And what Alec did next was we looked at whether the biomarkers across these groups correlated with cognitive impairment. The amyloid didn't. It actually doesn't reflect damage. It reflects the presence of the pathology, but not neuronal damage. But tau did, correlated across the board with a number of these areas of cognition. GFAP correlates specifically with memory, two aspects of memory. And neurofilament light didn't correlate because probably the whole group had neurofilament light affected. So again, potential insights into the fact that this Lewy body MCI may have Alzheimer co-pathology. Now, the next question I wanted to talk about is vascular, because that leads us into interventions later. So not all progression is related to neurodegeneration. People can have strokes. They get worse when they have a stroke. Vascular risk may be important. Vascular changes are found in MCI and Lewy body patients. And they're associated, and we've done a couple of reviews on this, with cognitive and neuropsychiatric and motor impairment, and potentially treatable or preventable, but carefully. So if, let's say, you have a Lewy body patient or a Parkinson's patient, and you drop their blood pressure, blood pressure already drops too much. So we have to keep that in mind. So this is an example of what I mean by vascular changes. So these white areas are vascular. Down below, clinical vascular disease, small vessel vascular disease has a number of different manifestations. White matter disease kind of covers a lot of this ground. And what I want to show up here is we identified people in COMPASS ND with vascular pathology. These were somebody who we thought had vascular pathology clinically. But actually, there are white matter changes in people with Lewy body dementia, or in the whole spectrum of the cognitively impaired Lewy body patients, but also frontotemporal dementia. So again, we can't use this 100%. But the thing with vascular changes is they're potentially treatable and preventable. But carefully, this is where I was going. So this is a study which did cognitive testing people lying and standing. And these were people with Parkinson's who had orthostatic hypotension. And they were cognitively intact, except when they stood up, they had impaired cognitive function. It was a randomized study, so they kind of they varied the order of testing, but found that if you stood up and you had orthostatic hypotension, you had cognitive impairment. So if somebody comes in cognitive impairment, we always check their orthostatics. So just be careful about blood pressure management in the Lewy body population, and think about orthostatic blood pressure changes in somebody who has cognitive complaints. They may be prodromal Lewy body, or they just maybe have orthostatic hypotension. So blood pressure management is really important. Physical activity is also really important. So there's various types. There's resistance training, aerobic training, walking, dance, tai chi. What we don't really know is how much, how intense, how long, and how to combine these things. And often in the studies that have looked across the board, and especially in Parkinson's, but across the board, really control groups have been an issue. Cognitive benefits have been shown in a variety of different training modalities, but in our cognitive Lewy body group, there's very little data. What about combining it? So combining with cognitive training, it's something that the study I'm going to show results for did. And that, the question is, do you need to just do exercise? Is exercise enough? And the answer is not quite. This is what, in theory, we might get if we exercise. So the idea here is this is again focusing on Parkinson's. There's a prodromal phase, just like in dementia. If you exercise lifelong, maybe you can prevent it. And these are theoretical. If you exercise regularly, you might do better. Or if you started after you are diagnosed, you might actually do better than somebody who doesn't exercise. And actually, the data, this is again, these plots are not easy to look at, but show that in general, we have good evidence that exercising with Parkinson's, either before, during, or after your diagnosis, helps you. It also helps non-motor symptoms. Not all, but basically sleep quality is improved, depression is improved, overall Parkinsonism on a rating scale is improved, and quality of life is improved. So really worth doing. This is an example. This is going back to Parkinson's. This is a study called the SPARKS-2 study. And SPARKS-2 basically what they compared was getting people into to exercise regularly. They aimed for 4 times a week. So actually, the aim is for 4. 3 is okay, but we don't tell patients that. But the idea of this study was to actually put them in a heart rate range that actually made them work to a certain threshold. That's really important. And what was found in this study, which was published in 2018, was that if you exercised in the high intensity range, your Parkinson's didn't progress. It's a short study, 6 months, but really compelling to suggest that this might slow progression. The moderate range slowed less, progressed less. And then if you didn't exercise, this is about what you'd expect in 6 months in somebody with Parkinson's disease. This is the average progression over time. So this is a proof of principle that exercise seems to modulate the course of Parkinson's disease. So this has actually been, this is the study we're participating in called SPARKS-3. And what SPARKS-3 is doing is looking at the 2 intensity of exercise groups. So everyone gets exercise in SPARKS-3. We're monitoring them to make sure they reach their VO2 peak, and we're following them over time. But what's different about this, and again, it's an NIH-funded study, so the money is in the mail, I guess. Of course, we have the Canadian mail to deal with, but the money's supposed to be in the mail. And the idea is here, not only are we doing the exercise, but we're then we're taking away the supervision to see if this can be maintained and which group maintains the exercise. And again, this is a principle that, again, we'll get into what's being done in non-Parkinson's, but this is a principle that can be applied across the board. So that's where we're at. We don't have the final data. We're about 90% through recruitment. So the studies that have looked in aging and lifestyle, several have been published. So the FINGER study is a Finnish study. The MAPT and PREDIVA were other European studies. Look Ahead was focusing on people with diabetes and obesity. And what all of them has shown, FINGER, US Pointer, and Synergic, US Pointer I'll show a slide from in a second, and Synergic I'll talk about in a second as well, showed that we see improvement on cognitive function over time. And Synergic focused on people with mild cognitive impairment. US Pointer had a variety of risk factors. FINGER focused on people who had vascular risk factors. So all of these studies have shown improvement. And when you look back at MAPT and PREDIVA, which were negative studies, actually, if you looked at those with risk factors for progression of cognitive decline, they did better. And so the idea is that dementia can be prevented in those targeting those at risk. So Synergic was the study that was done in Canada by Manuel Montero Dasso, focusing on aerobic exercise and resistance training. These were combined with cognitive training and actually a high dose vitamin D, which was a bit of a bust. But the bottom line was the other arms were not. But the theory was that vitamin D might have anti-inflammatory and calcium effects and antioxidant effects and so on. So the idea is to really target different aspects of cognition or of brain function. And the results are here. They were published in JAMA Open. What was shown was a effect size of 0.56 compared to the control arm of the combined exercise and cognitive intervention. So it's a cognitive gain that basically forces people to focus, to do multiple things at once on the training, but that translated into everyday life and translated into better outcomes. So actually, this is a huge effect size, 0.56. 0.27 is actually what a number of the other studies that I'll show you had results for. So this led to basically, again, showing a significant and meaningful effect on the cognitive decline score. US Pointer study, important to mention, it was actually published this summer. It was a big deal at the Alzheimer meetings. Again, what they did was they did it a little bit differently. They actually had physical exercise, nutrition, and they specified intervening in these cognitive and social challenges and guideline-based health coaching. And the intervention arm had this done more intensively than the non-intervention arm. So the non-intervention arm had access to the information, but they didn't have as intense follow-up. So the intervention arm had an intense follow-up. And what they found was that over the 3 years of the study, that patients did better in both arms. And I shared the subway with Jill Livingston, who's the squiggle person, and she said, They both improved. They didn't show anything. So the bottom line is they improved in their cognitive outcomes. Another study, again, thinking about where we would go with this, is this Australian study. So in the Australian study, they basically targeted risk factors. But what was interesting about the Australian study is did it all remotely. So basically, it was remote intervention, having them learn about diet, manage stress. They had a global dementia risk score. Do they participate in strength training? Do they participate in aerobic training? So people did all of these things in the intervention arm, not so much in the non-intervention arm, although their global risk score improved in their non-intervention arm. And what they showed was a broad cognitive improvement. These were 3,000 people per group in a number of domains in everybody, but particularly so in the intervention arm. And these were across cognitive domains that would be relevant for dementia risk. So what about Canada? I'm going to end with Canada. So this is Surm Son, a grad student with Dr. Montero Dasso in London, Ontario. And she looked at risk factors like the Livingston study, like the Lancet Commission, and focused on Canada and Canadian data from the Canadian Longitudinal Study of Aging. And what she found was similar factors. Hearing loss comes up, a number of vascular risk factors come up. A lot of them were similar, but physical inactivity was higher prevalence in Canada. So that may be something that that is specifically important for Canadian audiences. So this led to the Synergic 2 trial. So Synergic 1, I told you, was an in-house based exercise intervention study. Synergic 2 was actually grown out of the pandemic. We were sitting there talking, I'm on the executive of that. So we're sitting there like, there's a pandemic. How are we going to finish Synergic 1? They were about 3/4 of the way through, and they had less dropouts than they expected. So we actually ended up analyzing those who had participated until the pandemic, but we didn't want to take away the intervention of the people who couldn't come in. So what was done was we turned it all to remote. So we did basically a forced pilot study of basically home-based intervention that was based on Synergic 1, sort of basically monkeyed around with what we could do. And then Manuel wrote a grant. We were all part of writing it, called Synergic 2, where the idea was doing it all at home and seeing what happens. And so the idea is this is a multi-center Canadian study, recruitment at 8 sites. We're a recruitment site. People can self-refer, and we're at about 8% through of people with mild cognitive, about 69 patients per site. We're recruiting really well, so we're at about 75, and we're going to keep going. It's a 12-month online intervention, randomized to one of two interventions. One is the home-based coaching intervention, which is very similar to Synergic 1, but at home. And the second is Brain Health Pro, and I'll talk about what that is in a second. So the goals are to see if we can improve cognitive function, look at the lifestyle factors, evaluate the effective intervention of lifestyle factors, kind of like the Australian study and Pointer, and evaluate the interactions between risk factors and improvement in cognition. And then cost effectiveness is also a planned analysis. And so the outcomes are this ADAS-Cog, which is a global cognitive scale. And secondary outcomes are other cognitive domains like the Australian study, and then looking at cardiometabolic risk factors, quality of life, and biomarkers and mobility and sleep. And so the risk factors. So if you don't have these, one of our major exclusions is people who don't have the risk factors. This was true of the Australian study, and this was also true of the Pointer study. People don't have risk factors. So that's good. So my coordinators say that, they ask me, well, this person really wants to participate. But they're doing all the good things, so they don't have to participate. They just have to know that they're doing the right things. So for this study, they have to have mild cognitive impairment on testing. They have to have low physical activity, which is not so difficult in Canada, as we've just learned. They have to have poor diet. There's a diet rating scale. Sleep quality has to be poor. They don't have to have all of these. They have to have one of them. So one of these factors that we can intervene on. The CADE is a risk factor for dementia scale developed in Australia. It's mainly vascular, if you look at the items. BMIs, elevated diabetes, hypertension, and smoking. So these are the risk factors that you need to get into the study. And again, I don't necessarily see, we do have good recruitment from our clinic. We actually have great recruitment from Adrian Wagg's talk to the alumni. And those were the two best recruitment approaches, my clinic and Dr. Wagg's motivational speaking. So the Brain Health Pro is the control intervention in this study. So this was actually and this is available online. Now it's just been rolled out to become available in general. It's an online educational modules on modifiable risk factors for dementia and cognitive impairment. And there's basically a bunch of modules for each of these topics. Eric Smith and I developed the vascular modules. A number of our fellows and students and team members actually helped to design these modules. And then we ran it through people with lived experience and older people to see if it worked. And it worked very well. There's a lot of chapters. So this is the control group. They get all the information they need. And we monitor whether they decline and whether they're doing anything, but we don't know if this works. We do have some sense it might work. This has been piloted. So Brain Health Pro, if you look at the website, they've actually piloted it in older populations. It seems to be very, very acceptable, and people are using it. And then the intervention is progressive exercise training, progressive online cognitive training, same cognitive training as we had in Synergic 1, diet recommendations with a nutritionist, vascular risk recommendations, a geriatrician actually with experience in vascular disease and interest in vascular disease gives them a call, and recommendations on sleep based on individual sleep patterns. And then again, we actually monitor what they do in terms of the Brain Health Pro as in the comparison group. So I guess the conclusion is mild cognitive impairment is a heterogeneous disorder. However, cognitive impairment is common with aging and in Lewy body disease, and identifying subtypes of mild cognitive impairment may be important for prognostication and specific management issues. And again, less is known specifically about each of the different subtypes. Synergic 2 is actually recruiting all people with mild cognitive impairment, including people from the stroke clinic, the movement disorder clinic, and the community as well. And non-pharmacological approaches need further study, but they're there. And the next phase of the Australian group is they're creating an app, and they're going to roll it out. They're going to study like 60,000 people and see how it can be rolled out to 60,000 people. And the response of subtypes of prodromal dementia is not as clear. Consider referral to a trial. But in the meantime, again, what we do in clinic, not everyone wants to do a trial. We kind of tell them about brain health support options that they might have, encourage everyone to exercise, encourage everyone to engage in social activity, and try to stay cognitively active. And we recommend the MIND diet, which is the Mediterranean DASH diet combination, which is really good. And again, remember that blood pressure drop thing. So for people with Parkinson's, if they lower salt, they might get hypotensive. So you kind of have to be a little bit cautious about how to recommend things. So with that, this is our number for referrals for Synergic 2. I'm hoping that all of us in the audience could be like this, but not all of us will. But we can always get to the finish line and eat the cookies. So with that, I'll stop.
Thanks, Richard. That was great information. And I like the fact that you focused on the non-pharmacological, because there's just so much coming at us with regards to pharmacological. So I don't know if you want to take just a minute to comment on the monoclonal therapies, or if you want to leave it as is.
No, I can comment on the monoclonal therapy. So I remember The Exorcist, so they can make you quite sick. So the monoclonal therapies have shown slowing of cognitive decline in people with mild cognitive impairment and Alzheimer's disease. Mild Alzheimer's disease. Again, probably subgroups respond better than others. The companies have not allowed subgroup analyses because they say, they were powered, the studies have been powered for a certain number, so you can't do subgroup analyses. But not everyone responds equally well. So I think the key will be to identify who can do well with those therapies, and then have a system in place to monitor for side effects. So I think they're really an advance, and I think they're a very exciting advance. There's a slowing of cognition, but there's not a stopping of cognition. People decline in both arms. And about 20% can develop ARIA, which is amyloid-related inflammatory changes on the imaging. So again, like I said, people with 2E4 alleles, ApoE, are really likely to get that. So it kind of may not be the best thing for them. So I think they're going to have a place. It's going to require a whole new infrastructure where geriatrics and we and people in medicine and everywhere are meeting to try to figure out how to get the infrastructure in place. So I think it's an exciting time. The effect sizes are less than exercise, less than like the lifestyle. But you could do both theoretically, except if you're going to have infusions every month and are getting sick after infusions, you might not be able to do both. So I think they're a huge advance, and I think they're going to come into the system. Whether it'll be the NICE in the UK has felt that they were not cost effective given the improvements we had. Canada, I think, will probably come out with. I'm guessing it'll be approved, and then your insurance will have to cover it. We can't get MRIs for people coming in and being admitted with brain tumors, so it's gonna there's a cost to the system, but I think they're exciting. And I didn't talk about the biology, but some aspects of what exercise might do is especially long term, it may actually alter the pathology it certainly alters plasticity, alters inflammation, alters general health, which of course is better for, function. But we also be maybe altering the pathology. So we are looking, for example, in Synergic 1 data, Manuel is trying to get some funding to look at the amyloid in the blood because we have blood collected in those and see if that changes over time, amyloid and tau, which we can look at.
I'll just say that at our community health fair a few weeks ago, Robin Harrison plugged home the message about vaccination. So that got through.
Good.
And of course,
that's a huge effect, 20%, 20 to 30% decrease with the old shingles vaccine, and now the new one even better.
Yeah.
So I mean, and then the other. So I mean, there is a question about in terms of the data of the confounding effects of education, which affects all your risk factors, including whether you're going to get vaccinated. But I have to say, I talked to a professor and he hadn't been vaccinated, so it's not perfect.
So diet and exercise is good for you. Some guys that turn mortality is not news. What's the long-term effectiveness of these interventions when the research team go away?
Yeah, so that's Synergic or Sparks 3 will look at that because we're pulling back on it. The obesity and diet study actually they've been following people for more than 10 years, and they're seeing that may be okay, but you certainly drop out in terms of your adherence, how much you do. So I think what we need is sort of a public health kind of system to help. I mean, if we put money into something, maybe we have free gyms for older people. One of my colleague in Dr. Carlson, Michelle Carlson at Hopkins, inherited this intervention study. Like the person retired and she said, here's a study you would like to do. You're a nurse, PhD nurse, you can do it. So what the study was, what they actually gave people in underprivileged areas in Baltimore, bus passes and a volunteer job, and they showed a lot of the same improvements. And so I think at a societal level, we can think of some interventions that can be sustainable. But yes, you drop off, and the studies focused on diabetes and glucose intolerance did not show sustainable effects, but people did okay. Yeah.
Such a public health issue, right?
Yeah.
So.
Yeah. Good. Question from the audience. So whoever
there was one here.
You monitor. Yeah. So. I can hang out if the people have questions after too.
I was wondering about autoimmune diseases like rheumatoid arthritis, lupus. I was surprised not to see conditions in that in the relationship, the modifiable the risk factors.
Yeah, so I think again, a number of autoimmune disease can affect our brain health. They directly, they can actually cause, cognitive impairment directly from an, inflammatory CNS perspective. They actually overlap with other autoimmune diseases. I think part of the issue is the rarity. And so this was looking at big, the ones that had the biggest population attributable risk. So there probably is risk. So certainly people with lupus and other things actually can have cognitive impairment directly, and also from the treatments which affect your vascular risk profile, your activity capacity, all these things kind of compounding. Somebody with COPD, lung disease, you're going to exercise less. You're going to have other risk factors. You're worried about your COPD, so you might take your antihypertensive drugs. So, I mean, I think they're there. And so I guess another message, again, kind of contrasting Parkinson's with general aging population, is in your specific disorder, which you got and you've got to deal with, think about these other things too. I think they're really important.
We do have time for one more, so.
Was there one in the back first?
Oh, was there one in the back? I apologize. Go ahead, Anna. Go. Okay.
Maybe just a more general question with exercise research, because exercise is so good. You know, like anything you look at it, it seems like exercise is helpful. Should we study it anymore? Should we all just exercise? It helps everything, it seems.
So that's excellent. So in Sparks 3 and in our Synergic 2 study, you know, a lot of my team, Lem, is an exercise physiologist, and I work with an exercise physiologist, keeping people do like the question that Bill asked, you know, keeping people exercising is hard. It's behavior. And actually, we did a guidelines on falls prevention in Parkinson's. Basically, if you have you're at risk for falls in Parkinson's, you should exercise, and that reduces your falls risk. But getting people to do it, doing it right, actually, there is a coaching aspect to it. So it's not just exercise. Not everyone can do it right. Some people need coaching. Some people need motivation. So coaching and motivation are important aspects of that. Now, the Australian study, I think they effectively showed that if you didn't have the coaching and motivation, the other group was shown all the right stuff. They didn't do it. You know, they did improve their overall dementia risk a little bit. So I'm not sure what they did. Maybe they were told to go to the doctor. They took their antihypertensive and their cholesterol lowering aids. But so they did have an improvement, but they didn't have the improvements. They didn't have the participation in the other domains, and they didn't do as quite as well. So I think it's a question of making that a priority. And I think, for example, coaching. I don't. You know, I think you have to get out and do it, and you have to have the coaching to help you do it right. I think that's the key.
So on behalf of the department, I just want to take this opportunity to thank Richard for parachuting in. It was really helpful. And just a reminder to everybody that we have our skits next week, and then we'll take a little break from medical grand rounds. And it's really slippery and crazy out there. So speaking of fall, please all be careful.
Exactly. Environmental factors, yeah.